Good morning, everyone. Welcome to the Foreign Correspondents Club of Japan here in Marunouchi in Tokyo. I'm Anthony Rowley, a current director and former president of the club, and I'll be acting as moderator today. And welcome to the latest of our deep dive events, as we call them, in which we ask expert panelists to look at topics of current interest. And today we're returning to Covid-19, our old friend, or enemy, I should say. We're going to be looking at whether it's still a threat or whether we can finally let down our guard. What are the chances of a resurgence of the pandemic in Japan, especially as more visitors from China and elsewhere visit the country? And what precautions do we need to continue taking by way of vaccinations, masking policy, etc.? There are many such questions as these, obviously, in relation to the pandemic, and to provide us with the answers, we have two eminent medical practitioners here today. Let me introduce them briefly in the order in which they were speaking. On my right is Dr. Gautam Deshpande, who is a US board certified physician and founding vice dean of the St. Luke's International University Graduate School of Public Health. And on my left is Dr. Thomas Lomax, who's a practicing physician and who has managed during the COVID-19 pandemic a subscription medical support service for various institutions in Japan. Both panelists have spoken at a previous deep dive event here, and we're obviously very grateful to them for taking time out of their busy schedules to give us an update this morning. We'll take questions after both panelists have spoken. So let me right away hand over to Dr. Deshpande. But first, let me say just a little bit more about him. As I said, he's a US board certified internal medicine physician who did undergraduate and master's training at Stanford University and holds a doctorate degree in medicine from the Pennsylvania State College of Medicine. He's been working in Japan for 12 years, caring for the foreign community as a staff internist at St. Luke's International Hospital and as the post-medical advisor for the US Embassy. He was founding vice dean of the St. Luke's International University Graduate School of Public Health, and he's a professor of general internal medicine at Juntendo University. He's published more than 80 peer-reviewed scientific articles with recently published work on COVID vaccine efficacy in the Japanese population, and he's a fellow of the American College of Physicians. He'll be joining Tokyo Medical and Surgical Clinic as a partner early in the new year. So with that, Dr. Deshpande, let me hand over to you. Thank you.
Thanks. And thank you for inviting us back to talk about this. Bottom line up front, when we sort of ask ourselves, is COVID-19 a continued threat? I think the underlying mantra is that it will never not be a threat, but in the same way that theoretically tuberculosis or HIV or syphilis or RSV are threats. The question is, how much of a threat do we need to feel that it is in our day-to-day lives? And that's what Dr. Lomax and I are here to talk to you today about. So I'm going to go ahead and share my screen. Can people see my screen? I can see my screen.
I'm not sure they can, actually.
All right. Let me share screen again. All right. There we go.
Got it.
Okay. All right. Sorry, there may have been a little bit of feedback there, but it should be. So in the lead up to this winter, and actually the lead up to last winter, we heard a lot about this triple threat. So whether COVID-19, influenza virus, and RSV virus, or RS virus as it's known here in Japan, would together contribute to a more deadly winter wave again. And let's talk a little bit about that. So to begin with, as everybody probably knows, worldwide COVID is slightly on the rise again. This graph is just over the last 1 month, and you can see a slow trend upwards in worldwide COVID numbers. But if we actually look at sort of COVID over the last year, you can see that that slow trend upwards is really significantly lower than the winter peaks that we had last year. So the question is, are we going to get to winter peaks again this year? How much of a threat is COVID itself? How much of a threat is COVID with the addition of RS virus and influenza? Now, Dr. Lomax is going to talk a little bit more about the mortality, but it's not just the numbers, it's really the mortality. And you probably all heard a couple of weeks ago, the World Health Organization said that mortality rates had dropped by 90%, 90% from sort of the peak mortality years of late 2020 and 2021. So this graph just shows death rates per million. And they went from a peak of, cresting over 7 deaths per million to really, one per million. So this is an impressive improvement. And that improvement, of course, has been pushed by worldwide infection rates, so natural immunity, as well as worldwide vaccination rates with some highly effective vaccines. So in terms of the threat that we feel from COVID, certainly in the medical community, there's much less of an overt danger to what we're seeing now. These numbers have kind of fallen into the range of what we see with a really bad influenza year or a really bad non-COVID-19 coronavirus year. And that certainly gives me a lot of relief, and it really should give everybody a lot of relief that we're probably not returning back to the 2020 and 2021 levels of mortality that we were seeing. If we look at Japan, so we can see that Japan is starting to trend up in terms of its mortality, but those absolute mortality rates are still really low. We're not going into the 5 per million. We're not going into the 7 per million. We're not going to the 10 per million. Japan is trending up into the 1.5 deaths per million range. And again, that's what we tend to see with a tough influenza year, which we've been living with for the last 100 years. Every 3rd to 4th influenza year will be kind of a tough influenza year. Okay, so to shift the conversation a little bit, if it's not COVID in and of itself that's really bad right now, how much is this triple threat? And just to review, the triple threat is influenza virus, so seasonal influenza, not one of these special swine flus or bird flus, but just regular seasonal influenza, combined with the RS virus, combined with COVID-19. And just to give you some background on RS virus, respiratory syncytial virus tends to infect little babies, especially premature babies, but it can be a pretty prevalent upper respiratory disease in children up until like 4 or 5 years old. The other group that's at risk are the very old or the immunocompromised. But by and large, this is a childhood respiratory disease. It's almost impossible to symptomatically distinguish between these three viruses. They all come with fatigue, they all come with fever, they all come with a measure of cough, a measure of scratchy throat. So really, when we put all of these into the pot, is this going to be a really bad winter for Japan? Well, let's have a look. These data are off of the National Institutes of Infectious Disease website. So far, this, as of November 28th, which is what we have data up until, influenza, we've reported 5,039 cases of influenza. The majority of those are in Osaka, followed by Tokyo, Kyoto, Naha, and then the other urban centers. These are not overly large numbers, and I'll show you that in graph form later. These are pretty standard, if a little bit weaker numbers than we've seen for influenza over the last 10 years. And let me show you where we are right now. I don't know if y'all can see my, my pointer, but the 2022 year is the red line, that's way down at the bottom, I think, hopefully, yep, there's my arrow. That's where we are in terms of influenza this year compared to the previous 10 years. So I know, I mean, prognosticating is difficult, and prognosticating in medicine and in epidemiology is even more difficult. But these predictions that we had that, people's masks are being taken off and now it's going to be a really bad influenza year, don't really seem to be panning out. So influenza doesn't seem to be the huge threat that we thought maybe it would be when we were talking about this in September or October. All right, okay, so if it's not influenza, how about the RS virus? Well, significantly more substantial numbers here in Japan for RS virus. There's 114, almost 115,000 cases nationwide, 12,000 in Osaka, 7,000 in Tokyo, and then kind of around the 5,000-6,000 case range in Hyogo, Fukuoka, and Kanagawa. These are much bigger numbers. And these numbers start to approach the COVID numbers in the last couple of days. There were 175, almost 176,000 COVID cases just 2-3 days ago. But how does this compare to RS virus in the past? And I just wanted to show you this graph. It doesn't show the data for 2022, but I wanted to show you that RS virus is a seasonal virus. So you have a peak kind of in the late summer, early fall. And then in some years you have another peak in the winter time. So we're due up to see if RS virus is really going to be the big baddie that we had predicted in the fall. And one reason we're worried about this is that if you look at 2018, 2019, 2020, and 2021. In 2021, we saw an enormous jump from 2020. In 2020, there were like 18,000 cases in Japan. And then in 2021, there were 200,000 cases in Japan. So it was that big jump. And we didn't want to see another big jump into this year. So drum roll, this year, the red line. The red line is our current stats, what we've collected thus far. This data is actually from Kanagawa Prefecture, which I gotta say has done a really good job in terms of their public health tracking. In fact, this data isn't available yet nationwide from the National Institutes of Infectious Disease. But at least in Kanagawa, which is a good proxy for Tokyo, we're not seeing an enormous rise of RS virus compared to, say, 2021. 2021 in that green line, and you can see that big spike that led to all those big numbers last year. So influenza, not really making a huge impact or bump, and RS virus also not making a huge impact or bump this year. Triple threat, the data doesn't support that. The data doesn't support that we're going to see this huge wave of 3 bad upper respiratory infections that are going to swamp hospitals or overwhelm the medical structure. All right, so the question is it over, right? Can we just all take off our masks and, kiss each other? Well, not quite. What we are looking at now is, of course, a new variant. And I want to assure you that I'm not being, I'm not sort of saying, oh my God, there's a new variant. No, of course there's a new variant. There will always be a new variant because this is a highly mutational virus, COVID-19. It mutates the way influenza mutates. There will never not be a new variant. So what are these new variants that we're watching now? It's these 2 guys here. It's the BQ1 and the BQ1.1. And why we're watching those closely is that they seem to be really efficient transmitters. So in the United States, they went from 27% prevalence to 68% prevalence just in the last 6 weeks, starting on the East Coast and then sort of moving across the United States. And they're already up to 36% here in Japan. BA5 has dropped to about 54%. So The BQ1, BQ1.1 will become the dominant strain here in Japan probably in the next 4 to 8 weeks. But again, I don't think there's any need for alarm because our data suggests that the vaccines still work pretty well against these new variants as well. And that data is, of course, preliminary. It's coming out of the United States. But there's no reason to think that the Pfizer vaccine and the Moderna vaccine are not going to confer the same or similar levels of protection against these newer variants that we're seeing. Okay, so this is my final slide. Anthony, do I have time still?
Yes, that's fine.
Great, perfect. Okay, so what vaccines are sort of in the game right now? Well, we have, of course, Pfizer, which is Comirnaty, the Moderna vaccine, also known as Spikevax, and then we have Novavax, that novel protein-based virus vaccine, and then, of course, Johnson & Johnson, still struggling along, still on the market. The efficacy for these vaccines, the longer we have the pandemic, the more data we have that shows that, at least for Pfizer and Moderna, we're still seeing greater than 95% efficacy against disease. It's somewhat, and especially for BA4, BA5 with these new bivalent boosters, very good efficacy. There's somewhat less efficacy against the BQ1 variants that I just mentioned, BQ1, BQ1.1. We don't have the full data on that though, because really these have just come to prominence in the last 6 weeks or so. And the studies that we have that were published in Nature and New England Journal of Medicine suggest that in sort of the in vitro lab in vivo setting, we might have a little less of a robust antibody response with the mRNA vaccines and these new variants. But we're still talking about efficacy that's probably greater than 90%. So is it over? Yeah, it's probably over. That's my take on it. Now, one interesting thing is that with these new variants and with the bivalent boosters that have come out, it seems that if you have prior infection, as well as getting the booster, you have an additive effect in protection. So in a way, I'm not telling people to go out and get infected. Please don't do that. But it sort of helps. And this is kind of in line with what we're seeing around the world. Here in Japan, about 20% of people, based on blood donation data, have been infected. Amongst the 20-year-olds, where my son is, the rates are up about 38 or 42% previous infection. For folks of my age, mid 40s into the 50s, it's about 30%. And of course, infectivity goes down the older you get. But I think this works populationally in our favor because it makes the currently available vaccines that much more effective in terms of a robust antibody response. So I am not being alarmist about this winter. I think it continues to be a threat. COVID-19 continues to be a threat. Good hand washing, masking in appropriate situations, such as the hospital setting, very tightly packed settings. But that hasn't changed since the beginning of time. So from my point of view, we are sort of getting back to normal. And that's my spiel. We'll have time for questions and comments later. And of course, feel free to email me if you have any other questions.
Okay, thank you very much. Reassuring last words, or final words, I should say. But quite a lot of data to absorb there, but I'm sure we can return to some of those points in question time. Okay, well, now we'll turn to Dr. Lomax. And as I said, during the COVID-19 pandemic, he managed a subscription medical support service for institutions including the Japan Council of International Schools, several embassies, and foreign companies based in Tokyo. I'm not sure, actually, Dr. Lomax, whether you are still producing that subscription medical support service, but I'm sure you'll tell us. Okay, he's a partner of Tokyo Medical and Surgical Clinic, a facility which has a 70-year history of providing care for the foreign community in Japan. Dr. Lomax graduated from London University, the Royal Free Hospital, in the year 2000, and he's worked in surgery and emergency medicine in St George's Hospital, London, for 5 years. Subsequently, he trained in general practice and passed as a member of the Royal College of General Practitioners in 2008, shortly after which he moved to Tokyo, where he's been practicing ever since. So, Dr. Lomax, over to you, please. Thank you.
Thank you very much. So let me just share my screen. There we go.
Microphone on, I think.
Yes, can everyone hear me? So yes, I'm going to talk more specifically about COVID in Japan. And I've tried to sort of limit this to the two questions I get asked most frequently. As Anthony very kindly mentioned, I did run a subscription service which basically analysed trends in COVID over about 2 years, but I stopped doing that over the summer, and that was not because COVID had gone away, but more because the institutions that I was working with had by then largely figured out how to manage COVID in-house without too much external support, which I think is a positive. Anyway, let's start. There we go. So, I mean, as you'll all be aware, at the moment, case numbers are rising. We're seeing this kind of, if you sort of search for the COVID data, which is increasingly dropping off the front page of publications, you'll sort of see that the daily numbers of infections are rising, and fairly substantial numbers of deaths are still being reported. Now, does this matter? How significant is this? I mean, I think the key question is, how significant is COVID going to be over the winter, over the next 3 months? And I've sort of split this into two parts. First of all, will there be a significant excess mortality, which is, excess mortality means either people dying from COVID or people dying from other diseases, and because they weren't treated, because the medical infrastructure was tied up dealing with COVID, which we sort of saw happening certainly in other countries, but not so much in Japan in 2021 particularly. And then, of course, the other particularly relevant question for the foreign community here is, will COVID-19 cause excessive disruption either to internal economic activity, business, freedom of movement in Japan, and will it again impact on international travel? And then the sort of second, so that's the kind of glass is half empty part of the talk. Those are the people who are worried about COVID getting worse. The other half of the talk is, the glass is half full. Things are getting better. COVID is less of a threat. Does that mean we can start to row back from the mitigation measures? Does that mean we don't need to vaccinate people anymore? A lot of people come in and ask me if I think it's important for them to be vaccinated, to have their 4th or 5th shot. And of course, as Dr. Deshpande sort of alluded to, can we all stop wearing masks? So I'll talk about that in the sort of second part for a few minutes. So, as we're all aware, COVID 2022 is not the same as COVID 2020 or COVID 2021. Population immunity is substantially higher. In Japan, the vast majority of people have been vaccinated, and a substantial fraction of people have been infected. So a lot of people, even if they're exposed and infected with COVID, just won't get as sick as was the case in the past. And of course, the medical infrastructure has adapted. There's more capacity dedicated to COVID. There are antiviral treatments available now. So generally, if you catch COVID, even if you're unlucky enough to get severe disease, your chance of a good outcome has improved. I think we think back to particularly the first half of 2021 before vaccination was widespread. COVID was thankfully relatively rare, but that was because of fairly tight social control measures. But it was frequently quite severe, and medical institutions often struggled to manage COVID. I think we're sort of looking to next year, 2023, when, of course, there'll still be substantial numbers of COVID infections, but I think it's reasonable to predict that they'll mostly be mild or at worst moderate. There will still be some serious infections, but by and large, it will be a manageable disease. So, having said all of that, as we go into whether you want to call it the 7th or 8th wave, another wave of COVID cases, what's the best metric that you can look at to assess how much of a problem is this? Is saying case numbers are rising, is that a good way of assessing how bad this 8th wave is compared to, say, the 3rd or 4th wave? Well, there are the case numbers. This is daily infections over the past 2 years since the whole thing started. The first wave in Japan was in August 2020, and that was the Wuhan strain, the original strain. And that peaked at 1,600 cases per day. And then sort of going through the subsequent waves, wave 2 was in January of 21. That was the alpha wave that was first detected in the UK. That peaked at a little over 7,000 cases. That same variant was controlled with fairly tight social control, restriction of movement. But it resurged in May of that year and generated another peak of about 7,000 cases. Then, of course, sort of around and after the Olympics, we had the Delta variant, which was first detected in India. And that peaked at a significantly higher number of cases, about 25,000. And there's some reason for thinking that was actually the worst wave, which I'll go into a little bit later on. And then, of course, this year we've had, whether you regard that February, March, April wave as being 1 or 2, I think is up for debate. So that's either the 5th or the 5th and 6th wave. That peaked at over 100,000 cases, but this is Omicron, so generally of a lower severity. And then through this summer, we had an even higher peak of cases. So we went up to 250,000 cases per day. At that time in August, Japan was recording the highest number of cases in the world. And then, of course, we're now heading up again, and we don't know where case numbers are going to peak this winter. But these are obviously not directly comparable. So the 250,000 cases per day being reported in this summer had less of an impact than the 25,000 cases being reported every day last summer. So I think just looking at raw case numbers is a poor metric, because the severity of infections has varied so much between waves. I think at best you can use daily cases to assess ongoing trends. So has the current wave peaked? Are case numbers falling again? But it's not a good metric to compare one wave to another. So if we can't use case numbers to compare one wave to another, what could we look at? Well, we can look at mortality. These are the same 7 or 8 waves assessed on number of deaths reported per day. And again, if you look at this, it sort of seems that things are actually getting worse, not better. Having said that, overall mortality in Japan has been very low by international standards. Obviously 52,000 deaths, we shouldn't trivialize that, but by international standards, it's extremely low. And as we see infections spread through very large numbers of people, that will naturally generate higher mortality numbers as more people at the end of life die sort of with COVID, but not necessarily entirely of it. So, people at the end of life, maybe in their 90s, who have chronic conditions like end-stage kidney or heart failure, then get COVID and die, they will be recorded as a COVID death, but actually a substantial reason that they've died will be down to their underlying conditions. So excess mortality, as I referred to earlier on, is a better measure, but it's much harder to calculate in real time because assessing the impact of COVID on wider healthcare is much more difficult. So if we can't use mortality as a way of gauging the severity of this wave, how about hospitalization rates? And again, these are hospitalization figures through the whole pandemic, going back to 2020 through to the present day. And again, if you look at this, it seems that things are just getting worse and worse. We're seeing more hospitalizations with each wave. But here again, the devil is in the detail. Hospitalization stats are problematic as well. Japan has an abundance of hospital beds, perhaps on a per capita basis, about 3 times as many compared to the OECD average. Thinking back to the first part of 2021, there were relatively few COVID-19 dedicated beds, and it was hard to get patients into them. There are now an abundance of hospital beds. A lot of COVID dedicated wards are largely empty. And we're seeing people with mild disease who in other countries will be managed at home being admitted to hospital as a criteria to be given antiviral drugs such as Paxlovid. So a 2021 COVID hospital patient is not the same as a 2022 hospital patient. And again, looking at hospitalization numbers is a poor way to assess relative severity of each wave. So my opinion, and I'm prepared to defend this if anyone disagrees with me, is that critical illness is probably the best metric to assess the severity of a COVID wave. There are reasonably consistent criteria for admission to intensive care, and intensive care admissions are a good measure of the impact of severe disease on the wider healthcare infrastructure. So let's look at the more significant and recent waves and how many people ended up requiring critical illness support during them. So this is the Delta wave. This is summer of last year, around and after the Olympics. And at this time, intensive care capacity was saturated. So I remember Dr. Deshpande telling me in August of 2021 that he had a patient in St. Luke's who needed intensive care admission, and there were no intensive care beds for COVID patients available in the whole of Tokyo. The patient ended up being transferred to Chiba. So that was really the medical infrastructure starting to sort of creak under the strain. And that was at about nationally 2,200 people in intensive care. Now, fast forward to the Omicron wave of the winter we've just come through. Although there were far more people who were diagnosed with COVID, the number of people ending up in intensive care was appreciably lower, though it was still significant at about 1,500 at peak. This summer, where there were yet more infections, people requiring critical care support had fallen substantially and peaked out at about 700. And then if we look at the current trend, it's, although obviously it's not trivial, we're looking at about 400 to 450 people in intensive care across the whole country now. It's noticeably far, far lower than with the Delta wave or even the Omicron wave of last winter. So severe illness is appreciably lower now than was the case 18 months or a year ago. And I think that's a very important point. So my initial question was, will COVID-19 cause significant excess mortality due to severe disease and the wider impact on healthcare this winter? And my answer to that in one word is no. I think it's highly unlikely that we'll see the sort of strain on medical infrastructure and the sort of mortality that we saw with Delta occurring over this winter. And then the second part is, will COVID-19 cause excessive disruption to economic activity, and will there be restrictions on international travel? And again, this is just my opinion, but the general trend now is to row back from restrictions, to loosen up restrictions as a consequence of COVID. So I think it's unlikely that we'll see the sort of restrictions on economic activity and travel that were instituted last year, although of course that's a health policy decision. So my answer on that's perhaps less well informed than on the first question. And then of course the final get out clause is that an escape variant, a variant not one of the ones Dr. Deshpande talked about, should we see another variant which wasn't covered by existing vaccines and also had a higher morbidity than Omicron, then of course all bets are off and things might get appreciably worse. So that's where I see COVID going over the next 3 months. It will still be a problem. People will still get COVID. Some people will get sick and some people will die, but the scale will not be the same as we've seen over the last 18 months. So that being the case, is it now time to put all of the COVID mitigation measures back into the box and sort of forget about them? Can we stop being vaccinated and can we all stop wearing masks? Briefly to touch on those two areas. First of all, vaccination. I mean, vaccination has had a profound effect, as Dr. Deshpande showed, 90 to 98% reduction in the incidence of severe disease in appropriately and fully vaccinated people. Its effect on limiting the spread of disease is more modest. So people are, vaccinated. If they catch COVID, they get it mildly, but it doesn't prevent COVID from spreading through the population. And I think particularly continuing to vaccinate the vulnerable, that's the elderly and people with comorbidities, remains our core strategy in limiting the impact of COVID across the population. Vaccinating lower risk people, and that's basically healthy people under a cutoff age of perhaps 50, 55 or 60, is of some benefit, but is perhaps less critical. So some countries, a lot of European countries have stopped vaccinating younger, healthier people on the grounds that they have relatively robust immunity and their risk of severe disease is very low. Japan hasn't taken that approach and is continuing to offer vaccination to young people. Having said that, uptake is poor. So this is Japan's vaccination campaign. I think it's been a great success. Uptake has been very high. You'll see that through 2021, the sort of double peak there is the vaccination and the second vaccination of more or less the entire adult population. And then you can see sort of 3 subsequent peaks of vaccination, which represent third, fourth, and fifth doses. And uptake has remained high. If you look at Japan compared to other OECD countries, we're sort of, standing with our peers, basically. 83% of the population have been fully vaccinated, comparing that to 82% in Canada and only 69% in the US. Now, direct comparison here is unfair because this is the proportion of people who are deemed to be eligible for vaccination. And in a lot of countries, a lot of European countries, that's age 12 and above. In Japan, it's age 6 months plus. So very low rates of vaccination in younger children actually drop Japan's figure. If you took that out, Japan would achieve more like 85% or possibly closer to 90%. This is from the Cabinet Office website. And you'll see that while vaccination in the general population fell to 67% for the third dose, in people over 65, that's the elderly by this classification, for third dose, it's remained over 90%. I did my own back of the envelope calculation. For fourth dose vaccination, it's over 80%, but in the general population, it's only 40%. So we're seeing a bimodalization of vaccination rates. Younger people are quite, extensively choosing not to go into fourth vaccinations, even though they're being offered. Older people generally are continuing to be vaccinated. And that's just the same statistic broken down into more refined age cohorts. And you can see here that children, age 5 to 11, uptake of vaccination is very poor. Only 6% of children age 5 to 11 have had 3 vaccinations. And even 12 to 19-year-olds, it's 44%, it's less than half. As we go up the age range, once you get to 50-year-olds, they're 79.3, uptake of vaccination is good. So the takeaway here is that people who need to be vaccinated are being vaccinated. People in whom it's kind of maybe less critical, uptake is falling off, but I don't think we need to be too concerned about that. So vaccination is a useful strategy, particularly to protect people going through this winter. I think it's good news that vaccination rates are high. And then finally, just a couple of minutes about mask use. So again, in the foreign community, I'd have to say a lot of people really don't like wearing masks and would like masks to be abandoned. Having said that, Japan kind of topped the league for the OECD in terms of minimizing the impact of COVID. Excess mortality in Japan was perhaps the lowest in the world outside of China, which is kind of special circumstances. And I think a large proportion of that has been down to extensive and effective and appropriate mask use. And let's remember that mask use in Japan has largely been self-policed, not because it's, mask use has not been mandated. People aren't wearing masks because they'll be fined if they don't. What would be the consequences if everyone decided today they were going to stop wearing masks in Japan? And should institutions, schools, restaurants, hospitals just tell their staff to stop using masks tomorrow? And if they did, what would happen? Well, we do have a fairly good idea of what happens if you abruptly stop using masks. This is from a fairly large study published earlier this year in the US. And this looked at what happened in schools. I think this was in Massachusetts, in Boston, after the mask mandate was abruptly lifted. So we went from a situation where everyone in these schools, and this is a population of 350,000, so it's a large study, everyone went from using masks. I think in about June or July last year, the mask mandate was lifted, and by and large, no one wore masks. So 25 weeks of this period of study, everyone wore masks out of this population of 350,000 people. The last 15 weeks, no one wore masks. what happened to the COVID rates during those 15 weeks? So statistical analysis of the infection data showed that during those 15 weeks, abandoning mask use resulted in about 45 infections per 1,000 staff and students. So that's about 3 infections per 1,000 people per week, which is fairly significant. And then, I mean, if we think about the situation in Japan, obviously it's not directly comparable. Background levels of COVID infection aren't the same. Vaccination rates are different, et cetera, et cetera. But still, because in Japan we're continuing to require contact tracing and isolation of contacts, an extra 3 cases per 1,000 per week for an institution would be fairly significant. So, I mean, I would probably recommend against institutions abandoning mask use, certainly, indoors and in crowded environments. That having been said, I wholly support the Japanese government's suggestion that people not wear masks when they're outside. I think that's largely unnecessary. But I mean, time and time again, when I'm outside, I like to look in people's cars, and I see people driving around in their cars when they're the only person in the car, and yet they're wearing a mask. And I kind of want to go and knock on the window and say, why don't you think of the car as a giant mask? You really don't need to wear a mask in the car. But I think people, a lot of people outside just feel this sense of obligation to show they're doing the right thing. And I think that's going to continue. And I mean, that's in stark contrast to, this is the UK, when mask mandates were lifted in July. Immediately, everyone went out and, enjoyed kind of wild parties in crowded spaces, and that generated a new wave of infections. So I think, even if you told everyone to stop wearing masks here, they're not going to do that. So the question is rather academic. And I mean, my opinion is that mask use will sort of persist more as a sort of social custom, probably for the next 2 or 3 years, or possibly even for longer. I don't think we'll see mask use falling back to 2019 levels for quite a long time. So that was really all I had to say about those 2 mitigation measures. I mean, brief summary. Yes, we should get vaccinated, particularly if we're vulnerable, and mask use still has some benefit and is likely to persist, whatever you feel about it as an individual. I'm happy to receive any questions. That's my email address. Thank you very much.
Okay, well, many thanks. Before we turn to general questions, perhaps I could ask a quick question of both doctors. Japan is lifting its border restrictions, and we're expecting, I think, probably that the level of visitors from China will rise as a result. Is this going to make a significant impact on the level of COVID infections, do you think?
Well, it will in China, yes, because there's no COVID in China, and there's lots of COVID. There's lots of COVID here, so I think it's more of a problem. I mean, I don't think the Chinese government will allow unrestricted tourism in and out of Japan, but I mean, if they did, you'd be looking at people coming from a region where there's very little COVID into a region where there's a lot of COVID. So they'd probably all get sick, and some of them would take COVID back to their hometowns. But I mean, as far as would I be concerned if I was in a restaurant and it turned out everyone else in there was a Chinese tourist? No, I wouldn't.
I agree. Briefly. I'd actually feel a little bit safer, and simply for the osmotic factor that Dr. Lomax mentioned, low prevalence area to a high prevalence area. Do I feel a little bit more nervous when I'm on a U.S. carrier, air carrier, coming back from the United States? Yeah, I do, especially because, again, coming from a high prevalence area to a relatively lower prevalence area, and folks aren't wearing their masks in a sort of contained air unit. That gives me more pause than from China to Japan.
Yeah.
I didn't wish to imply anything racist at all. I really meant in generally lifting restrictions. But let's move on to questions from the floor. Do we have any questions from the floor? Yes, Dennis, please. Usual. Identify yourself, please.
Dennis Normile of Science Magazine. I think this question may be a little bit outside of your expertise, but regarding vaccines, as your lists have shown, all of the vaccines used in Japan are foreign vaccines, which has a lot of public policy makers and scientists in Japan very concerned. despite putting a significant amount of money into developing vaccines, they don't have anything that has been approved for use. And I think the one that was supposedly closest, Angen,
That's Shionogi's product?
right,
Yeah.
was dropped.
Yeah.
Yeah, yeah.
And now Japan has this multi-billion-dollar effort to develop vaccines for the next pandemic. Why is vaccine development so lagging in Japan?
I think, I think that's a great question, and it goes not just to vaccines, but basically drug development across the board. And drug development is happening faster. We're getting more effective medicines faster across a wide variety of specialties and diseases. And it is now a game to show superiority over what's available. And it is enormously, when you have something that's as effective as the Pfizer or Moderna vaccines, it is enormously difficult to show superiority. So if you take the next bar, maybe we're not going to show superiority, we're going to show non-inferiority. It's really difficult to show that when efficacy rates are 95%, 98%. So nothing is going to kind of meet the bar of a very successful medicine that happens to come out first. And I think that that's Japan's issue right now, is that they're not necessarily going to show something that's better, which is what both the science demands and the market demands.
I mean, I'll follow up on that. I'd agree with that. And I think I'd say there's some underlying economic reasons for that. So the last vaccine that's kind of commercially used across the world was developed in Japan is varicella, right? That was first chickenpox, varicella, which I think is about 40 years old now. So Japan hasn't produced a new vaccine that they've been able to sort of export around the world for about 40 years. Some of that, I think, comes down to protection of the Japanese vaccine manufacturers. So until relatively recently, most of the vaccines were made by domestic companies, and it was quite hard until about 2007, 2008, Hib and pneumococcal vaccines were approved, and they were imported vaccines. Until then, largely it was a protectionist environment where Japanese manufacturers got their vaccines approved and foreign vaccines were kept out. And if you sort of go through the history of vaccine development in Japan, look at things like the MMR vaccine. So when MMR went into wide-scale use internationally, Japan made its own MMR vaccine, and when it turned out there was a significant problem with it, rather than abandon it and import safe MMR from overseas, they decided to cut out the mumps strain. So that's pure protectionism. Now, I mean, unfortunately, that's generated an atmosphere in which Japanese, pharmaceutical companies are not really incentivized to generate well-beating products. And I think there's an attempt to reverse that now, but that's off the back of 30 years of maybe an environment which didn't encourage Japanese companies to compete on an international level.
And I think that's an interesting point. The restructuring of the PMDA to fast-track things, the restructuring of science funding in Japan with this new AMD institution organization, the fruits of those reorganizations are going to take 15, 20, 25 years.
I mean, it's like again, we're off topic now, but like the aviation industry here, when Japan didn't produce commercial airliners for decades, and then trying to do so from scratch has turned out to be very difficult.
Dennis, you have another question, please.
Actually, just an observation. I was just looking yesterday at the scale of R&D spending by pharmaceutical firms. Japan only has one pharmaceutical firm in the top 20 by spending on R&D. The leader is Pfizer, spending something like $14 billion a year, and the highest Japanese firm was Takeda, spending like $4 billion a year, U.S. dollars.
Okay, I have a question, not exactly online. It's an email question sent to me a couple of days ago from one of our members, Joan Anderson. She says, I'm holed up in a very nice apartment in San Jose, Costa Rica, having contracted COVID last week, just before I was due to leave here to return to some conferences in the UK. As I am now recovering, blah, blah, blah. And my question would be whether, in retrospect, we've been lucky with COVID in terms of the success of the vaccines produced so quickly, and whether the panelists think the next pandemic might have worse consequences.
I think there's always an element of luck, but I think that this was research funding, and this was applying bench science to pharmaceutical development, and it was sort of identifying really good ideas that were 15, 20 years in the making, and then acting on them. So it was really good science rather than luck that made us, that allowed us to have access to these amazing, very effective vaccines so quickly. And I think that's the key. It took us about 12 to 14 months to develop these very, very, very effective vaccines rather than years and years and years. So to that end, I think each pandemic will be dealt with progressively more swiftly as we move on. Because now we're down to months to develop a vaccine, an mRNA vaccine. Who knows? Maybe the next big pandemic that happens in 25 or 50 years will be down to weeks. So I think each one, each new threat or pandemic will be a little bit easier to deal with. Tom, what do you think?
Yeah, I mean, I think that the big thing we're taking away from this pandemic that will kind of add to the armory in the fight against infectious diseases is the mRNA platform. And I mean, think back to 2020, I didn't have any confidence that we'd get an effective vaccine against COVID. Because if you look at other coronaviruses, non-human coronaviruses cause quite a lot of problems in poultry, for example. There's some fairly nasty coronaviruses that spread through chicken flocks. And attempts to produce vaccines against them had been pretty unsuccessful. So, it wasn't a given that the vaccines would work at all. That they worked to such a high efficacy against severe disease, I think was, exceeded my expectations, and I think that of a lot of other doctors as well. I think the technology going forward is not guaranteed to work against every other infectious disease, but it certainly adds to our armory. So I think we can be optimistic that as and when there will be another pandemic. It's a question of when, not if, but we have a sort of bigger armory of tools to fight it.
Right. Pier D'Amelio, you have a question, I believe. Go ahead.
Yes. Good morning. My name is Pier D'Amelio. I'm an Italian journalist. I have two very personal questions. First one, I contracted COVID at the very beginning in Italy, and I was out of it in a few days, a couple of days. And then I came back to Japan. I was very, very well off, started life as usually. Then I got 1, 2, 3, 4 vaccines. And since last year, I would say, since this spring, after the 4th dose, I started to develop very, very bad symptoms. And as you can see, I'm now with oxygen. I developed what you doctors call pulmonary fibrosis, progressive one. So my question is, since a couple of doctors suggested this idea, I'm all in favor of vaccines. I mean, I did it and I would do it again. But is there any chance that especially the last dose of this vaccine have possibly caused this fibrosis? First question. And the second question is about masks. You say that you would leave it up to the people in certain occasions to keep the mask on, which is okay. But what do you think about the fact that in Japan they use only this, totally useless surgical mask? I mean, in Italy, when we use the mask, we have to use the FFP2 masks, which are the ones that are supposedly more effective. The surgical masks are just totally nothing. Why you doctors don't tell the Japanese government that it's totally meaningless to use them?
Okay.
You want to handle this one, or?
Yeah,
There are
I mean,
two questions there, right?
two questions. So I think it's, I'm very sorry to hear that you've developed pulmonary fibrosis. That's extremely unfortunate. I have to say I'm not aware of any evidence of a link between vaccinations and developing pulmonary fibrosis. I fully understand why you would make a connection between the two, but that's the problem with vaccinations, is that, you know, people who develop a wide range of medical problems in the months after they've been vaccinated will often correlate the two, and you have to look across the whole population to see if there's a true relationship or not. And I mean, there may be some published data that shows a relationship between vaccination and pulmonary fibrosis, but I'm not aware of anything myself.
Nothing that directly links it in a causative way.
Yeah.
And even the correlational data, there's a lot of other variables going on.
Yeah, and I mean, pulmonary fibrosis, unfortunately, typically we can't identify a single specific cause. It does seemingly come out of nowhere. So
It's idiopathic,
yes,
Yeah.
exactly.
which means you don't know what it comes
Yeah.
from.
But it raises a great question, because one of the dirty little secrets that has been uncovered by the COVID pandemic over this last 2-3 years is how little we actually know about the human immune system on an individual variation basis. We have seen, a purported vaccine link with autoimmune activation. We've of course seen a direct viral link with autoimmune activation. 26% of people who get COVID will get long COVID, which is essentially an immune system gone haywire. If there's anything that we need to do moving forward here from the pandemic as it wanes, as the pandemic goes away, is to really understand why some people will develop pulmonary fibrosis either after an infection or after some kind of immune stimulation, and yet the majority of people won't. And that's the undiscovered country of medicine right now.
Yeah.
Okay. The second part of the question concerned masks, whether doctors are not telling people that the masks they're wearing are useless.
I mean, I have to say, that was more of a statement than a question, but I have to say it's one that I don't agree with, and that both Dr. Deshpande and I have presented relatively extensive data on the efficacy of surgical mask use. They're obviously not as good as the N95, high grade masks which we use in for certain conditions to limit spread of tuberculosis, etc., etc. But they do trap droplets, and I think one thing we've learned is that COVID spreads in droplets.
Yeah. I think there's plenty of data that says that surgical masks are effective, and it's a spectrum, right? I mean,
they're not 100%.
Right? It's sort of like getting blisters on your feet. Barefoot is worse. Thin sandals is next. Sandals is next. Sneakers is next. And work boots, nice padded orthopedic work boots, are the best. There'll always be a spectrum. And then it becomes, the question there, I think if there is one, is how much policy advice do we give as medical professionals or as other public health policymakers in pushing what's mandated on that spectrum, right? And you have the United States, which basically shed all protections very, very early. And then you have Japan that doesn't have mandates but has a very strong cultural mandate. It's a cultural mandate. Mask use in Japan is a fascinating cultural exploration. It's not a particularly scientific investigation. I did my master's in anthropology, so it's fascinating for me.
Well, you may not agree on my statement, but I wouldn't agree with your fascinating adjective. I mean, it's not fascinating at all.
Fair enough. Yeah, no, it's very personally affecting for some people.
Okay, Dr. Deshpande.
Okay, thank you very much.
Sorry.
Thank you.
Many thanks, Pierre. You raised a very interesting point about immune system, and I can't resist the temptation to ask you here about this, because how far can we strengthen our immune systems? I personally, for what it's worth, take every day echinacea, vitamin C, zinc, all those things. I'm in what's called a vulnerable bracket, I think, in a sense, but I've so far, touch wood, not contracted not contracted COVID, having had 5 vaccine shots. But how much can we do realistically to strengthen our immune systems against things like COVID?
Right. This is going to go a little bit into sort of my personal thoughts, sort of collating a vast amount of data that we have. I think that in terms of the things that we can change, eating a good diet that is filled with fruits and vegetables that, for precisely the reason that Tony said, it provides vitamin C in adequate amounts, it provides selenium in appropriate amounts, it provides zinc in appropriate amounts. That's huge, right? So a good diet, especially one that's rich in fruits and vegetables. And the other one is sleep. I know it just sounds so almost foolishly simple. And the more simple something is in medicine, the less people will follow it, right? Getting more than, if you're a younger person, getting more than 5.5 to 6.5 hours of sleep per night. And if you're an older person, getting more than 8 hours of sleep per night. And this has been shown in a variety of small studies over the last 50 years that sleep is one of the best preventers of upper respiratory infections.
Interesting.
Yeah, I mean, I think most of the data that you look at on supplements is actually fairly weak. I'm not saying that there's, if people choose to take multivitamins or a number of other supplements, that there may be some benefit. But I think we're sort of touted that benefit by manufacturers quite heavily. I think the evidence that, for example, if you exercise regularly, your immune system's better is much more compelling to me. And I mean, the really, really obvious things like avoid excess alcohol and don't smoke. I mean, I think there's very compelling evidence there. Yeah. But, no one's marketing that quite in the same way as people who are marketing supplements.
Now, I think, one of the exciting things about immunology over the next 20 years is really looking at individual genetic variations. Yeah. Why are some people born with, stronger immune systems, quote unquote? They never get sick. Whereas some people are born with, what seems to be weaker immune systems. They get sick twice a season, every season. So I think moving forward, there's probably a role for sort of personalized immunogenetics.
Immunogenetics, that's a good term. Okay. Actually, we had a virologist here a year or so ago who told us we should eat blue cheese and natto. Yes, Kurt.
Fermented foods.
Can you go to the microphone, please, if you would?
My name is Kurt Sieber. I'm an associate member. I went from 1 to 5. I went all through. And I must say, particularly in Setagayaku, where I'm living, that the services we got were absolutely excellent. And we were very positive about it. But for my wife is Japanese. For her, the situation is exactly the same. About additional what to do, I'm not a friend of Trump, but through him, the vitamin D3 has been coming up, and I discussed it with a number of people, and I'm taking 2,000 IU per day, and this is a very strong, helping with the system, the personal system itself. So I mean, I have nothing to prove of anything, but that's my own personal experience. There is a little bit extra also, and I'm told that in Japan, because you eat a lot of fish and you have a good could, well, it's my very, very small, but the what would you call that? Oh, sorry.
Okay. Could you phrase a question,
didn't get
Kurt,
it.
please, if you
Yes.
don't mind?
So no, I have no question.
Oh, I see.
I'm just, well, what I'm adding in addition, I mean, very simple is I'm gargling every day 3 times very, very strongly. And so far, I must say, also I'm very old and supposed to be very, very, in a difficult position. I've never had any problems. I have other problems, but not this one.
Fair enough.
Thank you.
Okay. Do we have to send any questions online?
Vitamin D3, if you can make
Okay.
a statement about that, is that just belief or is it really useful?
Yeah.
A couple of years ago, vitamin D was a hot topic for research funding. Does it help with abdominal pain? Does it help with mood and psychological symptoms? Does it help with immune function? The data is really mixed because in small studies, it seems to be correlated, not causational, but correlated with better functioning in a variety of different organ systems. But in these larger pooled studies looking for an actual trend, we've not been able to reproduce the benefit.
I went through all of this, and more sort of referring to your question about does it protect you against infection. And I looked at there were a lot of large studies that individually didn't show benefit, but I found a meta-analysis
That did.
that pooled data from a number of large studies and collected a data set of like 100,000 people who've been given vitamin D supplementation, and in the meta-analysis it did show a statistically significant decrease in incidence of infection, particularly through the winter, which is when people's vitamin D levels will naturally fall. I mean, I think it was about 15%, but if you think of the number of respiratory infections that occur through the winter, if you could avoid 15% of them, that's quite a lot, actually.
It's worth it.
So, I mean, the public health advice in the UK has shifted to recommending that most people take vitamin D now.
Yeah.
Yeah.
And for certain populations, especially darker skinned people in the United States, that is very much our recommendation.
I mean, in the UK, it's recommended for older people, children, darker skinned people, women, pregnant women, women of childbearing age. So it's like, well,
Pretty much everybody.
doesn't exclude many people, that advice.
We are saying D there, D for
D,
David.
yes, D.
Yes. Okay. Dennis, yes, please.
Dennis Normile of Science Magazine again. I'd like to go back to mask use. The study, Massachusetts school study.
Yes.
Could you, I don't know if you can put that up again, but
Just have the
I think you
title.
said there were 3 additional infections per 1,000. Was that right?
It was a 40-week study,
Right.
and the first 25 weeks of the study, masks were mandated in schools.
Right.
And then the following 15 weeks of the study, after the mask mandate was withdrawn, masks were almost entirely abandoned.
Right.
And they basically compared infections within the school population against the general population to
Right.
sort of see what the change was. And they calculated that during those 15 weeks, there were 44.9 additional infections above what you would have expected per 1,000 population. So that's approximately 3 per week. I can send you the link if you like, though.
So there are roughly 45.
45 over the 15 weeks when they weren't wearing masks. Additional infections above what they would have been had the trend from the previous 25 weeks been maintained.
Right. Do they give a percentage? How big of a jump was that, percentage-wise?
Well, I mean, it's 0.3%, right? Well, I mean, that in terms of number of infections. Oh, you mean against the general?
Against the baseline.
I'd have to go back to the original
Right,
paper.
right.
But you're right in that you can't directly extrapolate that data to Japan. You can't say you'd get exactly 3 infections per 1,000 because it depends on the rate of infection in the background population, right?
No, I'm just asking because exactly how effective masks are seems to be an
Right.
unsettled question.
Well, I mean, even that study wouldn't answer that question because people acquire infections outside of school, right? So there'll be a certain, and when they stop wearing masks in school, some of the COVID infections will still occur outside the school environment. I mean, the best small scale studies that I looked at that asked that question were from right at the beginning of the pandemic. So there were two. This is about air travel and should you wear a mask on a plane. So there were two flights where there was one COVID case on the plane that were compared. So there was an Air Vietnam flight that went back from London to Ho Chi Minh in March of 2020. So right at the beginning of the pandemic, when people thought COVID was just happening in China. And there was one Vietnamese lady on this flight who had COVID, and no one on the flight wore a mask, and 15 people got infected from that one index case. So at about the same time, the Chinese government flew a whole bunch of people back from Singapore who were on a trip to Singapore from Wuhan. And again, they identified, I think, 3 cases on that flight going from Singapore back to China, but they made everyone on the flight wear a mask. And there was 1 excess infection on that flight. So 3 cases generated 1 infection with everyone wearing masks. And on the Air Vietnam flight, 1 infection generated 15 infections with no one wearing masks. And then when they went and quizzed the guy who got infected on the Chinese flight, he said he took his mask off because he didn't like it. So, if you accept that as being a failure of the treatment, then the treatment was 100% effective in that rather sort of small contained setting.
Yeah, the follow-up question is, you seem to give masking a lot of credit for Japan's
Yes, I do.
superior performance.
I mean, I don't think it's entirely down to masking by all means, but I think it has a significant effect. Would you agree?
I absolutely would. I would give masking 50% of the credit. I would give Japanese being very quiet in if they talk and when they talk. The other 50%. Yeah.
Hard to measure that, I think.
Well,
But did you see that? There was that thing on the TV. This is a pen.
Yeah.
Right?
There's ways to actually put
Found that to be
radio.
quite racist, actually.
Well, yeah. I mean, the way that was presented was pretty sensational. But you can actually take radioisotopes and have people do breath studies, and then watch how much they speak. And it's not so much that English has more P's and P's produce more. It's just that
People
Americans talk louder and
There are good studies basically measuring the volume of liquid that you express when you talk or laugh or sing or shout. And there's a very close correlation between volume. So if you talk quietly, there's a fairly low rate of droplet expression. If you sing or shout at someone, it's fairly high. Now, I mean, we all know, go onto a train in Japan, even pre-pandemic, what's it like? It's quiet because people either don't talk at all or talk in kind of hushed tones. Go on a train in London or New York, people are shouting, right? There's a crazy guy talking to himself in the corner, and people are arguing.
And it sounds so funny, right? It sounds so funny to say that this cultural behavior from country to country is such a powerful mitigating factor. And it sounds funny because it's essentially unenforceable. We can't build policy
You can't
around
make
it.
everyone quiet in Europe. You can't say, okay, now we'll have to talk like Japanese people. It's just not right.
Do we have any more questions from the floor? I have 2 quick questions to conclude, if I may. One is, viruses have been around for a long time and they've been mutating for a long time. Is the COVID a super virus in the sense that it's likely to continue mutating longer than other viruses in the past and therefore present a threat? That's my first question. And the second one you may not wish to answer, but now that China is getting very serious apparently about vaccination, can it catch up quickly in vaccinating its population? So I'm not sure who'd like to take that one first.
I don't see COVID-19 as a super virus. I think it's mutating at the same sort of general mutational rates as its other non-19 corona brethren.
And I mean, all of these viruses we live with, from sort of measles onwards, they're basically zoonotic. I mean, they're largely, at some point, they cross the species divide from animals. And I mean, the advent of agriculture resulted in significantly more disease because we live closer to animals and we got more zoonotic transmission.
Yeah.
So that's been going on for 10,000 years. And I don't think COVID is any different from any of the other host of viruses that have made that same species jump.
Yeah. And in terms of its mutational rate, influenza, non-COVID-19, coronaviruses, adenoviruses, these are all pretty fast mutators. So.
I think 10 years from now, when it's just another of the kind of whole spectrum of viruses where we live with, it won't be any different from the others. It could be wrong, but I don't think it's a super virus.
Yeah.
And on the China issue, China now seems to be getting very serious about vaccinating, but is it too late for them, or given the advances that we've seen, can China quickly make up lost ground and get its population vaccinated in time to control the incidence of the disease?
I think yes. As long as they have, or they choose to use a highly effective vaccine, that's the first step. And the second step, if they put a blanket policy on their populace and says, we are by hook or by crook gonna get shots into every arm in this country, they can catch up in 2 weeks.
But vaccination rates have been consistently poor in older people in China, and I've never really, I'd sort of like to speak to a China expert about why is that. And across the world, vaccination rates correlate very strongly to how much people trust their government. So in countries where people, maybe they're not totally happy with their government, but by and large they feel it's an honest broker, mostly people choose to get vaccinated. In countries like, Russia's a good example, where a lot of people don't really trust the government. They often express that by refusing to get vaccinated. Now, why is it that a lot of older people in China don't want to get vaccinated? Is it a sort of subconscious expression of lack of trust in the authorities that they're not expressing through any other means? I don't know. But I think that's the sort of key missing piece of information, is what's the motivation in that 40% of the elderly population who are as yet unvaccinated.
Fascinating. We go back to culture rather than science.
Was your optimism predicated on China importing foreign vaccines or using its own?
They haven't approved the mRNA vaccines, have they?
I don't think so. And really, to me, they
haven't got their own
but
proven mRNA vaccine.
They could reverse engineer one of the currently available ones. It really doesn't matter how they get there, as long as they're using something that's highly effective.
I'm skeptical. If they genuinely do remove all of their current rather onerous COVID restrictions in a short space of time, some of the statistical analysis showed that COVID would infect like 98% of the population within 2 to 3 months. And I think getting everyone vaccinated in that time frame is probably pretty difficult, actually, especially if they don't have a really effective vaccine. Now, I think what China will do is produce fantastical statistics to show that no one died of COVID. And I think doctors in China will be lent on to write something else on the death certificates. There's some evidence that's happened already. There's a good article about that in The Economist this week.
Oh, really?
Yes, no one died of COVID in 2021 in China, not even one person. But apparently, historically, it's been seen as a failure if someone dies of an infectious disease. So if you're a doctor and you sign someone as dying of tuberculosis, then you're admitting that the state has failed to control tuberculosis. Or if there's a lot of syphilis, then measures to control syphilis, which are the duty of local doctors, have failed. So it's better to write something else. Heart failure, lung disease.
Okay, one last call. Anyone like to ask a question? If not, we are pretty well against time. Well, not speaking too loudly and not wishing to spread droplets, let me thank our two panelists for a fascinating explanation and discussion. I personally found it very useful, and I hope you have too. So thank you very much for giving your expertise.
Thanks for having us.
And let me, again, I think you came on a previous occasion, but probably your honorary memberships have expired by now. So
yes.
Dr. Lomax, that's
Thank you
yours, a
very much.
renewal for 1 year. Dr. Deshpande, that's for you.
Thank you so much.
Thank you very much indeed for your
Thank you.